practice, milestones, and the extent to which the profession has grown both in training and in practice. Welcome with me, Dr. Rwandembo Wilson Mugisha, who is going to take the first part of the presentation on the subject of interest, which is the history of medical laboratory practice and training in Uganda. Dr. Wilson Mugisha, please take it off from there, as the audience is eagerly waiting to listen to you. I thank you so very much. And I welcome everyone to this afternoon session. Questions will be asked after his presentation. You have about 30 minutes to deliver this presentation, but we will be willing to listen to you as much as you can present. We thank you and welcome you.
Thank you, Jackson, for that kind introduction. And thank you, members, for logging in. Thank you, God and the executive who gave me the opportunity to make this presentation. I want first of all to start by apologizing. There are some few typos in the slides, but then never mind, it is not a print. It's just right. I want to start by saying that medical laboratory technology in Uganda.
Have we lost the presenter, or it's my side that I'm missing out? Okay.
Yes, we lost him.
You lost me. Do you hear me now?
We can hear you very well. And God, make sure that the slides flow with the presenter's rhythm. Thank you.
Thank you. Thank you. I want to thank you very much for allowing me to present this, and I want to thank the association and the CPD committee for having chosen me and found me worthy that I should be making this presentation. Secondly, I want also to apologize. There are some few typos you can find in this, but never mind, because this is not print. If we had to make it for print, we would make those minor typos. I want right from the onset say that this is rather an interesting and a confusing subject, because we are talking about very many cadres of the same discipline who have had a different path of development. And therefore, it is very difficult to make it coherent and have it be given a chronological order of presentation, because the cadres we are not following each other as if you start from laboratory assistant, technician, technologists, and scientific officers. But let us start this way, that the background of this of medical training and the medical laboratory training in Uganda started at the beginning of the century, and we owe it really to the epidemics that were in this country. There are so many epidemics of malaria, trypanosomiasis, diarrheal diseases, sexually transmitted diseases, to mention but a few, but they were rampant and they were taking toll. They are killing in numbers. When Dr. Albert Cook came in 1897, although he was a doctor, had come as a missionary from Church Missionary Society and had come to preach the word of God. Next slide. But what caused him a problem is that as they were preaching, whenever they would make the planned crusades, they would find very many people were for burials, and there was a very serious problem that almost in every village you find a burial almost every day. In fact, at the beginning of the last century, and at the end of the 19th century, they made a mini census, and they found that actually the population was at a level of extinction because the birth rate was lower than the death rate. And therefore, this was very worrying. And the missionaries discovered that very soon they will not have sample to preach to. Next slide. And therefore, the two missionaries turned their point back, and they became back to being health workers. And very soon as they started working, they discovered actually that the workload was too much. They discovered that the workload was too much, and they started training helpers. That's the slide later. They started training helpers, and the training of these helpers are the ones which later became the original trainees of this. The organization of training and the hierarchy of in the service is also still very new. We have just recently attained legal recognition. That recognition, the year is 2001, not 1995, but it is 2001, when the Allied Health Professionals Council was put in place. And scheme of service, it actually came out in January 2019, and we have had the first commissioner being what? The first commissioner being in office for the first time since Uganda became a republic. So what we learn from here is that when we are developing a cadre, when you are developing a profession, you have to be resilient, you have to be patient, you have to engage in advocacy, you have to wait. It takes time. You have to wait, it takes time, and you have to keep on teaching. You have to keep on teaching people, you have to keep on recruiting and recruiting. I had told you that the two health professionals, when they saw the rampant death, they turned back to being health workers, and they established their headquarters at Mengo, at the current Mengo Hospital. And as they started working, they found work was too much, and they started recruiting the staff. Some of the workers who are their porters, who were helpers, they started training them in some simple clinical procedures, and that was the beginning of the training for all sorts. But this time, let us go to the laboratory training. The slide keeps on getting lost. And so when they started the training, each person who was having a skill, be it a midwife, be it a doctor, be it a laboratory person, they would train people to assist them. But there was no coordination, there was no curriculum, there was no program, there was no examination, there was no certification. There was no certification. So everybody would train according to the needs of the area and according to the needs of the supervisor who wanted it to be assisted. Next slide. In 1929, there are some other trainings which are taking place earlier. The doctor started in the second decade, and the clinical officers, whom they are calling the Native African medicine assistants, and the local midwives had started earlier, but the laboratory training started in 1929 and was started by Dr. Tatwen, and this Tatwen was a bacteriologist working with the colonial government, and that was the official beginning of the training of medical laboratory assistants in Uganda. And they were trained at one day. If you see that dome-shaped building with that building of the government chemist, that was a school. That was a school. The entry requirements, after that time, it was a primary living certificate. And there was, of course, as I've said, there was an organized curriculum. Truly said there was a syllabus, and it was mainly apprenticeship, very little deductive teaching, and not qualifying. They would be awarded a certificate, a medical certificate. The same way I got medical form 5, this time they had a medical form, which was a qualification for the first set of medical laboratory assistants. This went on until 1956, when the training, until 1956, when the training was taken over by the International Institute of Medical Laboratory Technology. This year, in the 50s, it should be known that the Cambridge School Certificate, or O-level, started in Uganda in 1952. So actually, in 1956, that's when we have had the first graduates of Cambridge School Certificate, which is the O-level. However, bigger laboratories kept on training laboratory assistants, while the International Institute of Medical Laboratory Technology in the UK was training technicians, and they are giving a certificate of the Institute of Medical Laboratory Technology, and that certificate was called an intermediate certificate. However, bigger laboratories kept on, and the hospital kept on training laboratory assistants using the syllabus which we are using before which they are using before 1956. However, there was no examination arrangement. And this one went on until 1972, when public service found it was getting so many people who claimed to have been trained but had not been examined. And they formed the laboratory assistant training and examination program, which is called LATEP. And this one went on until very recently in the 90s. Next slide. This went on until recently in the 90s. The first chairperson of this was Mr. Vincent Oyero. Vincent Oyero was the chief medical laboratory technologist in charge of the Ministry of Health, and the Senator Root was an officer in public service. And that's how. And then they had the committee members. Another committee. There are some senior laboratory personalities, like the senior consultant and the clinical pathologist, and some senior technologists, and others who are thought relevant. So this one went on until the 90s, when the Ministry of Education liberalized education and laboratory training to formal institutions of training. So you could see while UK programs were taking place, there was also an official training which was taking place, and the working was continuing. It was kind of a fluid dynamic situation. Next slide. Then the laboratory, that was the government laboratory training. The missionaries also, as you know, missionaries were running parallel programs with the government, and they also participate in the training of the laboratory assistant. And Nsambya Hospital was the first one in 1946. Then it was followed by Chitovu in 1987. Next slide. Chitovu in 1987. Then Mengo in 1991. these two, Zambia and Mengo have progressed. They are producing now post certificate as a laboratory assistant and a diploma, but Chitovu is still producing certificate. We should also note that later in the 90s, Lacho also came aboard, but it came aboard when the institutions had already been liberalized, when training had been liberalized. Yes, next. So the training of a technician, this is how they have told you. They go to UK, and they will be assigned in some hospital where they did training, and they will get an intermediate certificate of Institute of Medical Laboratory Technology of UK, and that certificate was called intermediate certificate. And when they would qualify after 2 years, they would either come back to Uganda and work as technician, or they would be allowed to continue and specialize in one of the 5 disciplines of clinical pathology, that is microbiology, hematology, clinical chemistry, pathology, and hematology and blood transfusion.
Dr. Rwandembo, you can proceed. Dr. Rwandembo, have we lost you? We seem to be having a slight challenge, but I request everyone that's on the call to kindly mute so that you enable the rest of us enjoy the presentation as it's being made. Please mute so that if you're having some conversation in the background, we don't get attracted to that conversation. Dr. Rwandembo, are you facing any challenge? We can't hear you.
Hello?
Dr. Rwandembo, we had lost you. Are you having
I don't know what is happening. I don't know what is happening, but anyway, let us continue. We are saying that in 1960, Makerere University, together with Mulago Hospital, applied for permission to be an affiliated center for training medical laboratory technicians. And it was approved, and Mlago became the center for training for East and Central Africa. Are you getting me?
Yes, we can hear you. We can hear you, sir.
Okay. So Mlago became involved in the approved training center for International Institute of Medical Laboratory Technology, and we were training for East Africa and Central Africa. And actually, in 1963, we had the first final examinations, and from the Mlago Center, everybody passed. And the successful candidates were admitted for training for specialized diploma in UK. And some of the people of that time, some of them are still around. The Mr. Angumas and the group, they are part of the group who went to UK after they have started from Mlago. The lesson we get from here is that this level of success gave confidence to trainers at Makerere and Mlago, and everybody was sure that they are able to interpret and implement the curriculum, even if they are not the ones who have written it. In 1965, UK changed this training when we were just getting used to that we are training here and staying in UK for specialization. UK changed the training mode. They were specializing straight from starting. So when you are coming, you are going to be hematology technologists. And so they are only training specialists. Yet here in East Africa, most of the hospitals were general hospitals, and these highly specialized technologies, one knowing microbiology and not knowing hematology, wouldn't be useful here. So this arrangement is established in East Africa, and the East African countries had to look for a way of producing technologies that were relevant to them, and they developed the curriculum for East Africa in 1965. And they just actually adapted the curriculum which was being used by the Institute of Medical Laboratory Technology in UK and formed it for East Africa. In 1966, the East African countries got support from WHO and UNICEF and had a workshop in Kampala and a plan that training to develop a suitable cadre for East Africa. And the arrangement which had been phased out in the UK was adopted here. And this arrangement went on until 1977, when the East African community broke up. Now, in this arrangement for East Africa, we would have actually people sit examination for the diploma in one center. People from Uganda, from Tanzania would come in, would go to Nairobi and sit. People from Nairobi, Tanzania would come to Kampala. Each year they were rotating. And this one had brought a lot of harmony and confidence and togetherness within East Africa. The lesson we get from here from East African training is that the professional training should focus on service delivery. So you cannot just keep on going to UK because they are doing in the UK and you do it, and the East African program was developed because the new development in the UK was not suitable for the service delivered in East Africa. And of course, the breaking of the East African community also affected us. And the lesson we get from here is that the political environment is absolutely necessary if we have to succeed in whatever we are doing. Without political goodwill and a suitable political environment, it is always difficult to get the success. Now, as a result of the collapse of the East African community, each country now started developing its program. Although the Nairobi Nairobi, Kampala, and Dar es Salaam kept on changing exams. But they kept on modifying. For example, Uganda had to change its entry qualification in the program because we had very many area leavers, which was not the same in Kenya and Tanzania. And this one went on, this East African training went on until 2010 when we formed the Uganda Allied Examination Board. The way the thing was being done is that there was an examination board for medical laboratory technology, and the examination board would sit and produce questions, and they would administer examinations, and after the administer examination, the candidates who would pass would go to would pass, the results would be sent to Makerere, and they would get the Makerere University certificate. That here in Uganda, because MLT training, having come from the University of East Africa, it had come to it was succeeded by Makerere University. This arrangement went on until 2010 when UIF was formed. The bachelor's degree program, it's the concept started as far back as 1973, when the examination board for the East African Examination Board was a subcommittee of the Inter-University Council of East Africa, which has got now the offices in Chambogo. And the Inter-University Council of East Africa had a committee for medical education in East Africa. And the MLT Examination Board was a subcommittee of the Council for Medical Education in East Africa. In 1973, a proposal was solicited by Uganda into the committee that it is now time to have a bachelor's degree in medical laboratory technology in East Africa. And the proposal was accepted in 1974, and the proposal was approved in 1976, and the tentative curriculum was developed. And mind you that in 1976, we were coming towards the collapse of the East African community. And we seem to have remained a little quiet talking about it until 1989. In 1989, there was a workshop that was put under Makerere to see how medical laboratory technology was developing under the supervision of Makerere University, whether they were having harmonious and a progressive coexistence. And at the end of the workshop, it was agreed that yes, they have worked harmoniously, they are progressing, they are developing, and planned for having the bachelor's degree program started in 1992-93 academic year. At that time, I was around, I think, and the curriculum was developed. We used the people from the medical school, the senior medical laboratory technologists, the scientists, and the people from the School of Veterinary Medicine. And the curriculum was approved by the university faculty board of the School of Medicine at Mulago, and it was supposed to have gone to the Senate for approval and to be started in the 92-93 academic year. And unfortunately, it never crossed. It got lost in Katanga Valley. By that time, I had gone to UK, and when I came, I didn't find I neither found the curriculum nor the minutes, and as it was, nothing had ever happened. So as that thing was taking place, the veterinary department, I think, I was noting, and the Department of Veterinary Medicine should have been also having some notes because we had involved them. They developed another curriculum, changed a little bit, and presented to the Senate. When they presented to the Senate, the Faculty of Medicine actually wanted to try to put it down. They said, no, this curriculum looks medical, it cannot be veterinary. But the Faculty of Medicine didn't have any curriculum to present. So the Faculty of Veterinary took the day. And that was the first degree program which you need to give, where we need to give kudos to the Faculty of Veterinary Medicine, because the veterinary medicine is the first one to ensure that we get a degree in medical laboratory sciences in this country. And they deserve the praise for that. A big lesson we learned from here, that when you are planning for change, you should also plan for managing resistance. Another thing we should learn from here is that once you get the innovations and you put them on the shelf for a long time, it can be stolen, and it can be stolen, be picked and be modified and be presented by another fora by an individual has become interested, and you cannot have a valid claim that you have had it because it's your fault they have kept it on the shelf for too long. There were some reasons why these people did not want it, because most of the clinics were having clinic with laboratory services, and those were the levels in the 80s. If we are seeing in the 80s and early 90s, it would be RWANDEMBO clinic with laboratory services. But these laboratory services were being run by technicians, laboratory assistants, and technologists, and being covered by the doctors. And they thought that perhaps when this innovation takes place, the doctors, the laboratory technicians were going to get we are going to get license, we are going to get independence and start running the program themselves on their own, of course, which happened later. So usually sister professions, they have competition. So when you are making an innovation, you should be knowing that you are likely to get a co-wife to be studying you, and therefore you should, in your planning, you should be planning for advocacy and a continuous sharing of the advantage of the new innovation, so that we reduce the resistance. The BBLT design program, of course, when it was taking place, the health superintendent initially hadn't conceived it very well. And I think the Allied Health Professional Council had not also been consulted and had not taken part in the design. And therefore, the curriculum faced some problems of challenge of the clinical attachment. Some of the training was about to be taken place at night, and the areas of attachment were not very specific. However, these things were later sorted out, and the program got back to its foot and is now successful and continues to run. Postgraduates are also being run. We are getting masters and PhDs certification, which is also kudos to Makerere University, that faculty. But however, we have to learn the lesson that when we are starting programs, one is to involve as many stakeholders as possible in order to avoid the forward and the backward movement. However, you don't need to have. However, you don't need to fear making innovations. If you find that it's the time to do it, you do it, because when they notice, they can get corrected, and the world keeps on moving. And we should also learn that once an innovation has been implemented and you have produced the graduates, and the graduates have got a need in the community, they continue being produced, and being useful, and therefore you don't have to be what? Scared, so long as we follow a program when you have done your good research on the community needs, that your program is addressing a community need. The Umbrella University program came in 2000 and 2001, and the curriculum for BMLS was originated from the curriculum which got lost in Katanga when it was crossing the valley. However, because this curriculum had been on for a very long time, there was a lot of consultation, and at the time of starting the program, they did not suffer the issues which BBLT suffered. And of course, BBLT was also the firstborn. You know, the firstborn is normally suffer very many things. Even the parents are also learning how to parent children. For this Umbrella thing to take place, there was also a lot of force pulling and pushing to agree on the curriculum, the nature of the curriculum, how to be run, who would teach on the curriculum. All these were very big issues, and we had a lot of war and a lot of work and a lot of discussion in it. But the bigger thing is that eventually we succeeded, and the program is there. Some of the things that helped us, most of the people we met are the people who had been meeting in other public functions, and the people who are meeting in other public functions, discussing in the meetings, they were colleagues, so they are not very difficult. They are not new faces, as you shall be seeing later. Then another thing that helped us, we had the people who had a reputation. People had a reputation. People like Mr. Kirichan, who had taught almost every talk microbiology. People like Sebabi, the late Sebabi, who used to do a lot of research on hematology and immunology with Nzaro, who was actually at one time known as Sebabi antigen. Mr. Chochi Jongala in parasitology, and Mr. Nguma. They are teaching and their research products gave us really a good time. When you talk to them, when you give reference to them, they help the Umbrella program to be accepted easily. Then people like Professor Gilbert Abukenya, who was the chairman of the University Council, was also a colleague at Mulago as the dean of the medical school, and Professor Peter Mujenyi, who was JCRC, and Dr. Jessica Gajimba, who was the presidential advisor on HIV. Are you hearing? Who was the so all of these people, we knew them when we met. They made life also not very difficult because they knew whom we were. As of now, it is no longer a problem of how to start a bachelor's degree program. Like Sorot has started the bachelor's degree program, and it's quiet. Nobody even knows that they are starting, because now the plate is already set. The plate is already set. There are also private training in the universities, Kampala International University, University of Subi, Clark International University, and we also have tertiary institutions, very many tertiary institutions, which are taking, which are training in the laboratory technologies, the graduates, all sorts of training. In other words, the war of fighting to go into higher education is now won. a war of making higher degrees in medical laboratory technology is also won. A war of having technologists being made of the part of the faculty staff in public universities and the higher institutions of learning, all that is already now set in this country. Has our training had an impact on the community? Yes. The training has had responsible members of the society. We have practitioner laboratory technologists. We are feeding all the health facilities in the country. We have got university professors. You remember the late Professor Chironde. You remember the late Professor Apechu. All those are our colleagues and so many other professors and lecturers who are there. We have researchers. You have politicians and diplomats. You remember politicians. You remember at one time you had Mr. Vuru who was an member of parliament, and now I've got so many, I don't know the number. We had a polite, the late Dr. Ambassador Tomasange, who was also part of us. And of course, you should know that when I say that people in high positions, you remember Professor Chirondo Makerere University was also part of us. Achievements, yes. The profession has managed to develop quality educational programs. The profession has acquired a legal status. The profession had acquired a scheme of service. The profession is being considered for high profile and international jobs. Remember, Professor Chironde was actually the World Health Consultant for the whole of the Indian subcontinent. And we have got so many others. And we are participating in high international research agenda. You are seeing everywhere in JCRC, in the National Research Council, wherever here and abroad. And liberalized education has also spread and very many members. Challenges, yes, need to fight for more recognition. Ethical issues with some members of ours. Some members of ours are worshiping money more than the profession. And sometimes they do things which will make you like hiding away from being part of them. Capacity to develop independent national standards. We are not still depending on international standards. We cannot say there is a Ugandan standard. It is not South African standard. It is not. And we should be reaching that level where we cannot say this is a Uganda standard and everybody is copying it. Adequate funding for research projects. And we have also not had a lot of laboratory-based researches. And then another challenge is that you remember during the politics affected us. If you remember during the time of Idi Amin, we got the problem with the East African community. East African community made collaborative program of collapsing because of politics. And in conclusion, medical laboratory training in Uganda is already entrenched. It takes place in higher education section, in the higher education section of the country. Advanced degrees are already existing in different universities. Members of the profession are participating in high level research projects and programs, and the hierarchy in public services already. Asante sana, Mheshimiwa. Asante sana, Mheshimiwa.
Thank you so very much. Thank you so very much, Dr. Rwandembo. And apologies for whatever hasn't gone right in terms of projection and the interruption that kept interfering with your presentation. And also to the listeners and those who are online, I want to take the responsibility for that because I think we didn't make this very clear earlier on. But I want to thank you that nonetheless, we've listened to Dr. Rwandembo deliver his presentation. And I want to beg that we accord his presentation another 15 minutes of question and answer before we welcome Dr. Abu from Ghana. and that will enable us to make a comparative analysis between the two, or between the journey of development of laboratory profession and practice education in the two countries. That gives us good perspective, Eastern and Western regions of Africa. So I want to check quickly if there are any questions in the chat room, or if you have a question, you put up your hand. I will choose you to speak, and thereafter, in the next 15 minutes, we will be welcoming Dr. Abdul, who will be speaking to us shortly. Any questions? I can see. I want to start with Sam Okello. Give it a shot as I check in the chat room to see if there are any other questions that have been written there. Sam Okello, proceed.
Thank you very much, Chair. My name is Sam Okello.
Be precise.
Yes.
Thank you.
I didn't want the presentation to stop, but it has to stop anyway. My question to Dr. Rwandembo is that, does he see any problem with the training of lower levels as we thrive at a higher level? Does he see any problem with the training at certificate level, for example, in this country? Are we too many? Are we having too many training institutions that is making the quality to be diluted, or there's no problem? Thank you.
Thank you very much, Dr. Radeba. I will take two questions at a time. Let me have Vincent ask his question, then you will answer those. I don't want to overwhelm you with questions, so that you're able to answer in batches. I'll do batches of two. Vincent, proceed.
Thank you so much, Mr. Were. Good afternoon, everyone on call. Thank you, Dr. Mugisha, for the elaborate presentation. I request for your guidance, or you.
Vincent, we can't hear you. I hope you're not muted. We can't hear you, Vincent.
Mr. Were, yeah, no, okay. Are you able to hear me now?
Yes, proceed.
Are you able to? Yeah, thank you so much once again. Thank you, Dr. Rwandembo. Thank you, everything. I think we got it very clearly, but I request for you to clarify for us or guide the listeners on two things. One, we thank the government on the scheme of service for medical laboratory cadres in the country, but the uptake or the rolling out in different districts is slow. And most of the professionals usually cry to us in the UMLTA that some people say there is no way to recruit them, and we keep guiding the professionals to keep calm. Some have been put on the U4 scale for the bachelor's degree holders, but more are still left out. We request for your guidance through this presentation on the same. And then my last one is on master's degree holder in medical laboratory specialties, where we still have an issue under the Allied Health Professionals Council. These professionals are registered as, their qualification is registered as others. How do we move from there? How do we have this qualification recognized at Allied Health Professionals Council, and then probably be also put on the public service structure to be specialists like our other counterparts? I submit for now, Chair. Thank you.
Thank you very much. Allow me to give Dr. Rwandembo to answer those two. Then I will next take another two. Emmanuel, I've already seen you. You'll be next in queue. Dr. Rwandembo, you can respond to that.
Thank you very much, members, for the questions. They are very wonderful questions. The first question is was on the how are we looking at the lower training? Is it still good? Are they very many schools? Yes, there are very many schools. At one time, it was difficult to have these schools. There was a problem that could open up, and Uganda have very many schools and the technologies to do the training. That one was done. Now what is coming up is that the schools are too many. Yes, the schools are too many, and that's why I'm talking about the ESCO issues earlier. Some of the programs are for money making, but there's no problem with money making, except if you can, so long as you do it well. But the schools, yes, a little too many. But the issue is not that we are training too many for employment. The issue is the economy. As a senior technical advisor in human resource development, we have just rolled out a labor market analysis. And in this labor market analysis, we discovered that actually we are not yet anywhere closer to deploying according to the WHO standards. But according to the pocket we have, yes, the schools, there are too many. But according to the ratios, there are too few. Now, according to the trainings which do not have adequate facilities, really it is absurd, and I think the Ministry of Education and the councils should crack down on them. And if need be closed, because training is something which must be done the correct way. You are training health workers, you are not training business sellers. So yes, I agree with you, but the issue is not that there are too many, the issue is because we are too poor. As for the question of the scheme of service, yes, I think this one took us a lot of time. I remember we started in 2012 and we have ended it in 2019. Congratulations to all members for having participated in this. The scheme of service is there. Actually, a question we're asking, there are two actually in one. There is a scheme of service, but there is also the scheme, the deployment in the health facilities. I'm just forgetting how we call it. We have got so many vacancies.
I'm sure you're talking about the structure.
The structure, yes. About the structure. We have got so many vacancies. We have actually worked a very beautiful and developed a very wonderful structure. And this structure is not funded. And let me tell you, the advantage of the structure is it is there, and when the money will come, it will be funded. But this was the biggest opportunity to see that we can have a scheme of service and then a structure being done together, tied together. Keep on telling the people to be patient. The problem is not if anybody is refusing to pay them. The problem is that the country we are still poor. I don't know whether I have answered. Members, have I satisfied you?
Thank you very much.
Dr. Rwandembo, one more, maybe before you leave, I take the answers very strongly and I believe they are very okay. But the last one on it, I think the masters missed out.
Oh, the masters, oh yes.
Yes.
The masters think of how to advocate. Master, you see why they are finding why it is finding a problem. It is not in the system. When you go medical officer special grade, when they put them there in the other thing, in the other.
Let me, Dr. Rwandembo, you're done responding to that?
Yes, I am. I said, yes, let us work with the council to ensure that the scheme corresponds with the masters we are going to have, with the masters we are doing. Because when we are going to get medical special grade is reflected in the other council, it is also reflected in the scheme of service, and is also reflected in the structure. So we must find a way of working so that they keep on flowing, they flow very well, so that we are able to earn a qualification, get it registered, and be on the market with it.
Thank you very much, Dr. Rwandembo. Let me just give a little clarity on this. Not to use the blanket statement that the master's programs have not, or the master's graduates have not been incorporated within the structure. I want to give a bit of confidence to my colleagues looking at the national referral. And again, like Dr. Randebo put it, once resources are available and also with continuous lobbying, we should have these structures incorporating the lab specialists at the regional referral hospital. If you look at the scheme of service and study it very well, it has clarified on where each cadre should be deployed as far as government settings concerned. And therefore, I want to let people know that the master's graduates have been provisioned for at the structure of regional referral, national referral, reference laboratories. It's now, as we continue to advocate government to incorporate all these, we need to lobby, and like Dr. Randebo did mention of the progression that has been seen in the profession with our colleagues representing at different levels, including Parliament. We need to continue lobbying. But as far as I'm concerned and what I know, at the National Referral Hospital, we have even submitted requests for master's holders to occupy positions within the structure, which we have provisioned for. It's indeed an issue of us to continue lobbying and getting to the powers that be to have our voices listened to and heard. Otherwise, this scheme of service sets the tone and the opportunity for the profession to continue rolling and growing in all forms, because the public desires to have a better service that is provided by the clinical labs and also research labs. Emmanuel, you can proceed. We have just a few minutes to close off with that presentation, and we invite Dr. Abu. So summarize your question so that we have an interactive session with Dr. Abu. Please proceed.
Thank you so much for giving me this opportunity. I would like to acknowledge my former president, Dr. Abu Rahman. My name is Emmanuel Salifu from Ghana. My question goes this way, that in Ghana, we face a lot of challenges with laboratory physicians who attempt to overstep their boundaries in the medical laboratory operations. I am interested in knowing if your country experience similar challenges, and if so, how do you address that, or how are you addressing it? Or if it did happen previously, how did you address it so it can guide us in how we can also manage the situation in the community? Thank you.
Thank you very much. Next question is coming from Michael Atta. Then I close off and we invite another presenter. Michael Atta, ask quickly so that we can have the responses to those questions.
Hello?
Yes, proceed.
My question, I have some challenges with the screen. I can't see. I don't know if it is my network or for your place. I'm calling from Ghana. The screen. Sharing of the screen.
We can hear you, Michael. What is your question?
I'm saying that sharing of the screen, I'm finding difficult to see the screen over here.
Which presentation would you like us to share on the screen?
I just turn in and I can hear only this.
It's because they are not sharing anything at the moment. It's just questions.
Okay.
Okay, thank you very much. Thank you very much. Let me just read a few questions from the chat room so that Dr. Randembo can combine these in a response, and then we get to the next presenter. Quickly, I've seen somebody mentioned here. Onyutha says there are a lot of irregularities in the course units, especially in certificates and diploma program. That doesn't this compromise on the quality of the knowledge produced? Then the second question is why the diploma training still take much part of the certificate course units, hence 3 years long in comparison to the sister profession like nurses and midwives. I think that's from Onyutha. Then I've seen a question from the next one. Let me just check quickly. A question from Francis Ochen, who says, in the interest of growth and respect for our profession, do you think it is still relevant to continue training very low cadre professionals? That's question number one. Number two, we have seen countries with harmonized training curriculum that are implemented across universities. Would you, as a senior educationist, advocate for unification of training curriculum for each professional qualification other than leaving it to individual universities? Can we have one curriculum that is comparable or it's presented to all universities to follow in terms of training? Those are the questions I wanted to read to you so that you respond to that, and then we'll invite the next presenter. Thank you very much, and over to you, Dr. Randembo.
Thank you, Jackson.
You're far away from the mic. We can't hear you well. Please draw a little closer.
I didn't hear. Are you hearing me now?
Draw a little closer. Yes, I can hear you now. Yes. What didn't you hear?
Yes, I didn't hear the question very well from Emma.
From?
Emma from Ghana.
Oh, Emma from Ghana.
Yeah, I didn't get your question very well. But let me answer it so that
okay, so if I can repeat that, I am glad. I will be glad to quickly do that.
Please quickly do that. We are short of time.
So I raised the concern that in Ghana, we have the challenges of laboratory physicians encroaching the laboratory space in our facilities in Ghana here. And I wanted to find out if you are also facing same challenges in your country and how you are managing it, or if that happened previously, that you face challenges of laboratory physicians encroaching your laboratory, and how you manage to salvage those situations. If you can share that with us, so we see how we can also manage our issues in Ghana. Thank you.
Thank you very much, Yama.
I hope Dr. Randembo, you've understood his question and you've had it well.
I think he's saying how the technicians are finding problem when progressing.
Kindly draw closer to your mic. We can't hear you well.
I think he was saying that there is a problem of progress for the technicians.
I think if I can repeat for you the question, he's asking whether in Uganda we are having a similar problem where we have laboratory physicians. I hope you'll I think it's clinicians who have done medicine and then have ended up in the laboratory related disciplines, like, for example, clinical microbiology, hematology. And I think that's what he's asking, whether we have that challenge of coexisting or occupying that space where you'll have a consultant, clinical laboratory person, a specialized person in the clinical laboratory discipline, coexisting with the pathologist. I think that's what he's asking.
We don't seem to be having that one. I was finding that one very much in UK, and but to me too, I would think it would be a thing it was there if you're having the laboratory personnel and the clinical pathologist sitting together and discussing. I would find it would be beautiful. But let me go to number 3. Certificate and diploma training being low. I think the training we are having now is other than having those mushrooming schools, the training is much better because it is supervised and is having external examination, and it is easy to know the institution which is doing well, and it is easy to know the institution which is not doing well. And having external examination, we have already killed what we call a hidden curriculum. So that teaching takes place without knowing what is going to be examined, without knowing that they are going to examine a specific type of curriculum that is about to be taught in that semester. But of course, as an educationist and as a health worker, there is always room for improvement. And certainly, you are right to get concerned. And I should always get concerned until you leave this earth if you are somebody who is a professional and as an educationist. One curriculum would be one curriculum for each profession. How I wished would be. But the way the law is, the National Council for Higher Education, the law, university and other tertiary institution statute give the university academic freedom to design the programs according to their institution and according to the demands of society and according to what they think is necessary and is missing and can improve the world. Back to you, sir.
Thank you very much. I can see a question from Dr. Bello, who is asking what is the highest level of medical laboratory training in Uganda? I just want to quickly, picking from your presentation, that the highest level of training is a PhD in laboratory medicine. I think I've answered that one. Having ably received responses from Dr. Rwandembo, allow me extend a vote of thanks. We don't have much time, but I can do it on behalf of the rest of the members. We thank you very much, Dr. Rwandembo, for sparing time to make a presentation to this audience. And now, as you waiting to listen also to a colleague, and we compare notes on the practice of laboratory medicine, both in Western and East African regions, let me invite Dr. Abdul Rahamani. I hope you're online. I want to make a special introduction of your presence